The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everybody. We are gathered here for the next episode of TMD Demystified, and I'm Tony Urbanek. Welcome to this episode, which will discuss a very pertinent situation regarding the cause of TMD, temporomandibular joint disorder. And again, welcome to both the professionals, the doctors, the dentists, who follow us along on our podcast, and especially to patients who are increasingly tuning in or watching these episodes. I am finding out from all over the country and actually all over the world. But today's topic is entitled, Everyone on the Planet Has Two Bites. That is a true statement. And the difference between the two can cause TMD. So if that's a fact, then it is. Everyone on the planet has two bites, fact. And the difference between the two positions or two bites can cause TMD. It is important for both the practitioner, the provider, and the patient to understand what that is, what that means. To back up a little bit, of which I've discussed this before somewhat, but we're going to take a more focused dive, as they say, on this particular issue. There are three causes to damage the temporomandibular joint. You cannot develop TMD, temporomandibular joint disorder, with all of its disparate symptoms, which are headache, earache, jaw pain, neck pain, ringing in the ears, feeling of fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are the well-accepted symptoms from everyone, documented. But you cannot develop those symptoms unless it starts with damage to the temporomandibular joint. And you have to damage the temporomandibular joint in three ways. There are only three ways you can damage the temporomandibular joint. Three categories. One of them is well understood. Well, I can't say that's not a true statement. It is poorly understood because we don't understand bruxism very well. Bruxism, or clenching and grinding, is the first. We understand the motions, but we do not understand how anxiety, stress, and worry create, through the central nervous system, clenching and grinding of the teeth. We have a lot of theories. There are mechanisms we are aware of, but we cannot honestly say that we understand fully how anxiety, worry, and stress create bruxism. Some people do it, some people don't. Everyone is stressed, but that is the first way you can damage the temporomandibular joint. The second way is the most obvious way, which is acute trauma to the jaw or face itself, directly on the joint or to the jaw, to the mandible, which the forces will translate into the joint to the point where you can damage the joint, you can damage the meniscus, the disc, you can damage the interior surfaces, you can even damage to the point that you can break the jaw joint itself. And the third cause to damage the jaw joint is what we are going to focus on today, which is called functional malocclusion. We'll define functional malocclusion, first of all. As Voltaire is so noteworthy of saying, a very astute author and thinker 300 years ago, He always said, if you are to communicate with me, you must first define your terms. So we'll define a few terms. Functional malocclusion. Functional malocclusion is any occlusion. Occlusion meaning bite. Occlusion meaning the way the teeth fit together, well or poorly. You can have good occlusion, you can have bad occlusion. But the way they fit together is called occlusion, and a malocclusion is where they don't fit together well, and a functional malocclusion is when the teeth do not fit together to the point that it creates dysfunction of the jaw system. Dysfunction can be defined as not being able to chew well, not being able to open well, or functional malocclusion causing damage to the temporomandibular joint. So you can have functional malocclusion where it causes damage, or you can have malocclusion, which most of the orthodontists spend their time treating people who have crooked teeth. But crooked teeth is not necessarily a functional malocclusion. That's an aesthetic problem. You can have aesthetic malocclusion, teeth out of alignment. That's an aesthetics problem, which should be corrected if the patient wants, but that is not a functional problem. When the bite is bad enough where it causes dysfunction in chewing and overloading of the temporomandibular joint, which is right here, you overload that joint and it breaks down. It is damaged. So there are three causes to damage the temporomandibular joint. One is bruxism, clenching and grinding. The second is acute trauma, and the third is functional malocclusion. Now, what we're really here to discuss today is the difference between the two bites. Remember, everyone has two bites on the planet, and the difference between the two bites is what causes a functional malocclusion. So bite one, we'll use a few doctor words for the patients who are not trained in dentistry. There are two types of bites. The first is called centric occlusion. Of course, our dentists watching know this. This is basic dentistry taught usually within the first year of dental school. You will learn about the two bites. Number one is centric occlusion. Centric occlusion, another name for that is acquired bite. But let's call it, to be consistent, let's call it centric occlusion. But acquired bite is the bite that is acquired over time as the baby teeth, deciduous teeth, come in, fall out, and are replaced by permanent teeth, and on occasion can be assisted with the help of orthodontics, braces. Both of those are acquired over time. They're acquired bite being the same thing as centric occlusion, the occlusion where your teeth mesh best. Now, this is a model, and frankly, this model does not have a very good centric occlusion. You can see they don't mesh really well, but it is just a model. But you can get the idea. Where the teeth mesh on both sides and in the front, where they mesh best is what we call centric occlusion. Not everybody has a perfect centric occlusion. In fact, very few people do. But where they mesh well is centric occlusion. Centric relation is the position of the jaw joint that fits best in the socket. We call that the glenoid fossa, or the socket of the jaw. It's called the glenoid fossa, but it is a socket. And this is called a condyle, which is the ball, which fits in the socket. And when the ball fits well in its most comfortable position in the socket, we call that centric relation. So let me go over that again. It's actually, I remember being a dental student, the book I was reading kind of confused me. So hopefully I make this really simple. Centric occlusion is when the teeth fit together well, the best they can. And centric relation is where the jawbone and the condyle fits well in the glenoid fossa in its most comfortable position. It's also called rest position, usually in the most superior position. Now, the truth is, everybody on the planet has a difference between where the teeth fit together well and the joint fits together best. Now, that difference, this is technical, but very important for both doctors and patients to understand. That difference is usually pretty small, usually within a millimeter, millimeter and a half for the majority of people, and they can accommodate that difference. The difference being, you can see the motion of the mandible. The mandible is just one bone, has two sides, two jaw joints. They operate in unison, but as one side opens, the other side closes. As you know, that's how you chew your food. But the point is that everyone has a difference, and the majority of people have a small difference between where the teeth fit together and the joint is in its most superior. There's a variation on the definition, either posterior or anterior, but I maintain it's the most superior posterior position is the comfortable position, but there's a small difference, maybe a millimeter, maybe a millimeter and a half. And the majority of people can accommodate the difference as they chew and as they function with that small a difference. They don't know the difference. That's normal to them. That creates no pain. It creates no damage. It definitely doesn't create temporomandibular joint disorder. However, when that distance starts to increase beyond a millimeter and a half to 2 millimeters to 3 millimeters to 4 millimeters, the 5 millimeters would be a very large difference between the two bites. When you start approaching the difference between these two bites of 3, 4, 5 millimeters, it puts a tremendous load on the joint itself, going back and forth between the two positions. Actually, it's the motion of the mandible going back and forth between the two positions, one to get your teeth together so you can chew, and the other when the mandible goes all the way back to its rest position. And when that distance starts to increase beyond a millimeter, millimeter and a half, 2 millimeters, the larger that difference, the less the patient can accommodate that difference. And it starts to damage the inside of the joint, specifically, most easily, that cushion, the disc. We call that the disc or meniscus. And when that disc or meniscus starts to get damaged, first thing it starts to do is starts to get loose. The disc itself, the cushion between the ball and the socket, is a cushion. And in a healthy joint, that cushion is supposed to move a little bit and silently. And if it's silent and moves a little bit, you'll never hear it. But as the joint becomes damaged, the ligaments that hold the cushion in place, the ligaments that hold the cushion, the disc, the meniscus in place start to get loose. And the first thing that happens, it starts to click, 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 click. This is extremely common, but there is no pain. And so everyone ignores it. And it is pandemic in adolescent females. Why females? Why adolescents? Because estrogen exacerbates inflammation. The whole problem with damage to the joint is inflammation in the joint. That is why TMD is 90% females. Estrogen, the female hormone, exacerbates inflammation. So once damaged for whatever reason, whatever primary reason of those three reasons, but now we're talking about functional malocclusion, difference between centric occlusion and centric relation, the cushion starts to get damaged, and the ligaments that hold it in place get damaged, and the first thing that happens is get loose and starts to click, 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 click. That's ignored for years sometimes, but that is not a good sign. It should not be ignored because it's the first sign of developing TMD. The next stage of the problem, as I have explained before, is the disc cushion, meniscus, comes all the way out of position within the socket, balls up into a little ball in front of the socket. Now, when you go to open, you bump into your own cushion. You can't get past it for a moment till boom, it clicks back, usually with a louder noise, more like a pop. People described a difference between the click and the pop. And when the pop happens, it usually occurs with some pain. That's the first time it starts to hurt. When that thing pops back, kind of surprising, and then starts to hurt. And then when that's ignored long enough, then the disc and meniscus and the other parts of the jaw joints start to break down to get degenerative changes, and that's when you get into full-blown degenerative change of the entire joint, which can progress into serious bone loss and all kind of nasty things going on. But today we're just limiting the discussion to the two bites, which really are one of the three primary causes of TMD and very, very common. Half the population clenches or grinds. Not everybody has acute trauma, and not everyone has a functional malocclusion, but it is common enough where it generates a tremendous amount of temporomandibular joint disease. So to go over this again, according to Voltaire, centric occlusion is the position of your lower jaw, mandible, when your teeth are fully meshed together in their most stable and balanced contact. And centric relation is defined as the most superior posterior position of the mandibular condyles within the socket or glenoid fossa. Everybody has two bites. When the difference between those two positions gets large, then you start to get damage to the joint. You get enough damage to the joint, it will create inflammation. Inflammation is the body's response to damage. It is the body's response to heal. It is the body's response to help. But over time, if it does not heal, and this is a very important issue to understand, over time, if it's ignored or doesn't heal, and the headaches and earaches are misdiagnosed as ear infections and migraine headaches, and the ringing, fullness, dizziness are misdiagnosed as Meniere's disease, rather than ringing, fullness, dizziness coming from the temporomandibular joint. It goes on for years, for decades. The damage gets worse and worse, and it needs treatment by resting the joint properly, using a proper device and protocol. Use the proper device and protocol, and chronic inflammation will go away. Inflammation itself is a good thing. Inflammation is the body's response to heal, to try to heal. But when it doesn't heal, it develops what we call chronic inflammation. Chronic inflammation is a different cell response. It is a different cell type in emphasis. And chronic inflammation leads to damage of the tissue, damage of the meniscus, damages the synovial lining of the joint, and eventually significant amount of bone loss can occur. And of course, the symptoms related with that, which we won't repeat for the third time. So that's the story. And if the patient or doctor wants to fix the problem, once the chronic inflammation goes away and the symptoms goes away, you're still left with a functional malocclusion. And we see that all the time. So once we get a patient with that are symptom-free, and this isn't every patient, but it's a subset of all the patients we see, we get them pain-free, symptom-free, using that device and protocol. And then the proper thing to do is go on and fix the functional malocclusion. Depending on how significant the functional malocclusion is, most of the time it just takes orthodontic care, braces of one kind or another, not always aligners. You can't do everything with aligners. They're good, they're useful for sure, but you cannot do every kind of motion and fix the teeth with just aligners. Sometimes you need to do traditional braces with brackets and wires. And in some cases, when you have significant change, we're talking 5 millimeters, 4, 6, 8, 10 millimeters difference between functional malocclusion. That is where the oral or maxillofacial surgeon needs to come in, because the problem cannot be fixed just by moving teeth. You actually have to do the surgery on the jaws, whether it be upper jaw, lower jaw, or both. Most of the time it's just one of the two, upper or lower. Occasionally things are so severe that you have to operate on both upper and lower simultaneously. But it is a doable deal. Oral and maxillofacial surgery on the jaws is called orthognathic surgery, which is nothing more than Latin meaning straight jaw surgery, to bring the jaws in proper alignment. The entire jaws are so different in their positions, whether it be the lower jaw forward, which we call a class 3 jaw, or the lower jaw way back, which the whole lower face is dished in. That's a class 2 jaw, class 2 position, but the jaws need to be aligned so it's properly aligned in the front, with the assistance always, almost always, with an orthodontist. And combined surgery and orthodontics can significantly improve the functional malocclusion, the facial profile, and the function, and totally alleviate all the potential for having any further damage to the temporomandibular joint, because you removed the functional malocclusion. Now, these are concepts that I acknowledge the patients have not been aware of, and that is why I went through this hopefully kind of simply and slowly, but I can assure you, attest to the fact that most general dentists and even some orthodontists whose specialty is the movement of teeth do not fully understand the consequences of the difference between centric occlusion and centric relation on the health of the temporomandibular joint, the health of the patient, and function. One other fact I just want to throw out there, and I've been doing a lot of research and study recently, and a patient brought it to my attention here yesterday on Monday, which is my one day a week where I still see patients, brought it to my attention, which kind of surprised me. She started talking about the influence of chronic inflammation in particular areas throughout the body, in particular chronic inflammation within the temporomandibular joint, influence on the other organs of the body, adding the prevalence of other diseases like heart disease, lung disease, diabetes. And that has been proven, that has been shown. So there's a depending on how you look at the health of your own body, and you should, walking around with chronic inflammation anywhere, whether it be the knee or your hip or chronic inflammation within the GI tract, anywhere, can severely influence other diseases within the body, because the exudates from the chronic inflammation cells circulate throughout the entire body and have effect on the other organs in the body. So the higher the level of chronic inflammation you have within the body, the more potential you have to get other diseases either started, encouraged, or made more severe. This is science. This is what is being shown out there. And one other fact that I did some research on, I don't recall talking about it, but periodontal disease, and a lot of this came out of studies, good studies from the periodontal doctors who have studied extensively on the amount of chronic inflammation associated with teeth, creating influence on heart disease, lung disease, pancreatic disease, and even brain problems, brain fog. So that a bit of knowledge has been well worked out, but what I wanted to say is that the dynamics of the temporomandibular joint, because it is such an unfolded joint, it has just a huge amount of surface, I have calculated that the surface area within the temporomandibular joint itself has more surface area, more potential to have chronic inflammation than 28 teeth, which the periodontists have studied in detail. So the point being, you can have more chronic inflammation coming from the temporomandibular joints than you have if you have chronic inflammation of 28 teeth, which is quite a stunning statement, but very true. So with that said, I think I've made my point as how important it is to understand the third cause of damage to the temporomandibular joint, which is chronic inflammation brought about by functional malocclusion. And functional malocclusion is created by increasing differences between bite 1, centric occlusion, and bite 2, centric relation. I hope I didn't confuse you. I hope I sorted that out for you. It's a pretty simple concept when you look at it from the mechanical point of view, and it's a mechanical issue. It truly is. It's a mechanical issue, and then it is helpful if you understand a little bit about cell biology, which I also have a degree in. If you understand a little bit of how cell biology, then you can take a review of how the cell biology in a joint can create damage not only within the joint, but in other parts of the body. This whole thing works as a system. It's a self-correcting system. If you'll help it self-correct, it will do most of the work, which brings me to the statement that good doctors understand that we just help the body. We don't do much. We're just try to help that body. We try to help chronic inflammation heal itself. That is a true statement. So with that being said, I look forward to the next time that you tune in, that you watch the next episode of TMD Demystified. I enjoy educating you. I enjoy helping you understand the focus of this podcast, which is TMD, temporomandibular joint disorder. There is no reason that we need to have millions of people, 90% females, millions and millions and millions of the U.S. population have temporomandibular joint disorder and misdiagnosed as migraine headaches, Meniere's disease, and ear infections constantly. It doesn't have to be that way. And it is my mission to sort that out and improve that situation. By the way, I'd like to announce that this podcast is going to continue on in the same form, but there will be in addition, I've decided to begin doing a Saturday real-time presentation, real-time streaming on Saturday. The first one, inaugural stream, will be on April the 4th, Saturday at noon Central Time. So I announced that you'll be looking for it, and you can see that on YouTube as the inaugural episode of TMD Demystified, where you can ask questions and participate in the streaming process itself. With that being said, I hope you have a good week. I hope you tune in next week, and I look forward to some of you joining us on the real-time stream inaugural, April 4th, 12 noon Central. I am Tony Urbanek.